Let's talk about obesity. Obesity is defined as an abnormal growth of adipose tissue due to an enlargement of fat cell size, that is hypertrophic obesity, or fat cell number, that is hyperplastic obesity, or a combination of both. Obesity is associated with an increased risk of multiple health problems such as hypertension, type 2 DM, dyslipidemia, OSA, non-alcoholic fatty liver disease, degenerative joint disease, and even malignancy. It is important for physicians to identify, evaluate, and treat patients with obesity and the associated comorbid conditions. The steps in the evaluation for obesity are to focus obesity-related history, physical examination to determine the degree and type of obesity, assessment of comorbid conditions, determine the fitness level, assessment of the patient's readiness to adopt lifestyle changes. The obesity-focused history should include the following questions. What factors contribute to the patient's obesity? How is obesity affecting the patient's health? What is the patient's level of risk from obesity? How does the patient find difficult about managing weight? What are the patient's goals and expectations? Is the patient motivated to begin a weight management program? And what kind of help does the patient need? Symptoms and diseases that are directly or indirectly related to obesity: cardiovascular, that is hypertension, congestive heart failure, cor pulmonale, varicose veins, pulmonary embolism and coronary artery disease; endocrine are metabolic syndrome, type 2 diabetes, dyslipidemia, and polycystic ovarian syndrome. Respiratory include dyspnea, OSA, hypoventilation syndrome, Pickwickian syndrome, and asthma. GIT include GART, non-alcoholic fatty liver disease, cholelithiasis, hernias, and colon cancer. Symptoms and diseases that are directly or indirectly related to obesity: musculoskeletal, that is hyperuricemia and gout; immobility, osteoarthritis, especially of the knees and the hips; low back pain, carpal tunnel syndrome; psychological, depression or low self-esteem, body image disturbance, and social stigmatization; genitourinary is urinary stress incontinence, obesity-related glomerulopathy, hypogonadism in male; breast and uterine cancer, pregnancy-related complications; neurologic it is stroke, idiopathic intracranial hypertension, melalgia parasitica, and dementia. Vast majority of the obesity causes can be attributed to behavioral factors that affect diet and physical activity patterns, but history may suggest secondary causes that require further evaluation. That may include PCOD, hypothyroidism, Cushing's syndrome, and hypothalamic disease. Drug-induced weight gain also should be considered and include medications for diabetes, that is insulin, sulfonylureas, thiazolidine diones, steroid hormones, antipsychotic agents like olanzapine, clozapine, and risperidone, mood stabilizers like lithium, antidepressants like TCAs, monoamine oxidase inhibitors, paroxetine, metrazapine, and valproate, gabapentin, and carbamazepine. Three key anthropometric measurements are important for evaluation of the degree of obesity, that is weight, height, and waist circumference. BMI is calculated by weight in kg upon height in meter square, or as weight in LP upon height in inches raised to the power of 2 into 703. Skin fold thickness, it is called measured by Herpindan skin calipers, side armpit triceps, biceps, subscapular, and suprailiac. Sum of all should be less than 40 mm in boys and less than 50 mm in girls. Advantages is large amount of body fat is just under the skin. It is most accessible, assessed by rapid and non-invasive method. Disadvantages: it contains poor repeatability. Waist circumference and waist hip ratio. Increased risk of metabolic complications for man if waist circumference is equal to or greater than 102, or for women if it is equal to or greater than 88. Waist hip ratio greater than 1 and 0.1 Base strip ratio greater than 1 in men and greater than 0.85 in women indicates abdominal fat accumulation. Obesity associated comorbid conditions. The evaluation of comorbid conditions should be based on symptoms, risk factors, and upon high index of suspicion. Patients at a very high absolute risk include established coronary artery disease, presence of other atherosclerotic diseases such as peripheral arterial disease, abdominal aortic aneurysm, and asymptomatic carotid artery disease, type 2 diabetes, and sleep apnea. Obesity is fundamentally a disease of energy imbalance. All patients must learn how and when energy is consumed, diet, and how and when energy is expended, that is physical activity, and how to incorporate this information into the daily lives, that is the behavioral therapy. So the obesity care involves attention to dietary habits, physical activity, and behavioral modification. So the primary focus of dietary therapy is to reduce overall calorie consumption. Guidelines from American Heart Association and American College of Cardiology recommended initiated treatment of calorie deficit of 500 to 750 kilocalories per day compared with the patient's habitual diet. Alternatively, a diet of 1200 to 1500 kilocalories per day for women and 1500 to 1800 kilocalories per day for men, adjusted for the individual's body weight, can be prescribed. The reduction of goal is losing up to 1 to 2 lb per week. The calorie deficit can be instituted through dietary substitutions or alternatives, choosing small portion sizes, eating more fruits and vegetables, consuming more whole grain cereals, selecting leaner cuts of meat and skimmed dietary products, reducing consumption of fried foods and other foods with added fats and oils, drinking water instead of sugar-sweetened beverages. Exercise alone is moderately effective for weight loss, but combination of dietary modification and exercise is the most effective behavioral approach for treatment of obesity. Most important role of exercise is to maintenance of the weight loss. The recommendation of physical activity guidelines for Americans in 2008 is that adults should engage in 150 minutes of moderate intensity or at least 75 minutes per week of vigorous intensity aerobic physical activity per week, performed in episodes of at least 10 minutes and preferably spread throughout the week. Lorcaserin is a selective 5-HT2C receptor agonist with a functional selectivity of 15 times more than that of 5-HT2 receptors and 100 times than that of 5-HT2B receptors. For lorcaserin, the medication should be discontinued if the patient has not lost at least 5% body weight by the period of 3 months of treatment. Peripherally acting medications with orlistat is a synthetic hydrogenated derivative of naturally occurring lipostatin lipase inhibitor. It is produced by mold Streptococcus toxicity. The drug is a potent, slowly reversible inhibitor of pancreatic gastrics and carboxylester and phospholipase A2, which are required for the hydrolysis of dietary fat into fatty acids and monoglycerols. Orlistat acts in the lumen of the stomach and small intestine by forming a covalent bond with the active site of these lipases. Taken at a therapeutic dose of 120 mg TID, orlistat blocks the digestion and absorption of approximately 30% of the dietary fat. After discontinuation of the drug, fecal fat content usually returns to normal within 48 to 72 hours. So the bariatric surgical procedures are laparoscopic adjustable binding, laparoscopic sleeve gastrectomy, the Roux bigastric bypass, biliopancreatic diversion with duodenal switch, biliopancreatic diversion.